That tightness in your chest when you climb stairs, that breathlessness that didn't used to be there 5 years ago, that nagging awareness, somewhere in the back of your mind, that the arteries carrying blood to your heart might be slowly narrowing, quietly closing down, year after year, while you take your pills and hope for the best. Your body has been sending you signals, not random ones, specific ones. And for years, the standard approach has been to manage the numbers on your blood panel, while the real question, what's driving the damage inside your arterial walls, goes largely unanswered. Today, I'm going to translate what your cardiovascular system has been trying to tell you. And when you hear the message, a morning drink that costs about $1 a glass is going to make a lot more sense than you'd expect. Well, before I go further, I am not a doctor. I am not a cardiologist. This is not medical advice, and I am absolutely not telling you to change, reduce your hours, or stop any medication your doctor prescribed. Heart disease is the #1 killer worldwide, and it demands serious medical attention. What I am sharing today is published research that may complement, not replace, your existing treatment. And always talk to your doctor before adding anything to your regimen. With that said, let's look at what the science actually shows. Here's something that changed how I think about cardiovascular health. Your body is not a collection of parts that randomly break down. It is the most sophisticated system on Earth. And when something goes wrong, when a signal fires, when a symptom appears, it's not because the system is failing. It's because the system is communicating. The symptom is the signal. It's your body raising a flag. Now, what happens when you take a medication that lowers a number on your blood panel without addressing the process that's driving the damage? You're not fixing the problem. You're turning down the volume on the alarm. The alarm is important, but so is the fire. I want to be clear about something. Emergency cardiovascular medicine saves lives every single day. If you're in acute danger, chest pain, suspected heart attack, arterial blockage, medication and medical intervention are not optional. They are essential. But for the chronic, slow-burning process that narrows arteries over decades, that's where we need to start asking whether we're just managing numbers or actually addressing the process underneath. And that's where something remarkable shows up in the research. Let's decode the signal your cardiovascular system is actually sending. When plaque builds up inside your arteries, a process called atherosclerosis, most people think of it as a plumbing problem. Cholesterol gets stuck to the walls like grease in a pipe. Too much grease, the pipe clogs. Clean the pipe, fix the problem. That's the popular image. But it's not what's actually happening. Atherosclerosis is not a plumbing problem. It's an inflammatory disease. The current scientific consensus, supported by decades of research, is that arterial plaque develops not simply because cholesterol is present in the blood, but because the arterial wall becomes damaged and inflamed. When the endothelium, the thin inner lining of your arteries, is injured by oxidative stress and high blood pressure or other inflammatory triggers, LDL cholesterol particles penetrate the damaged wall. Once inside, those particles become oxidized, chemically altered by free radicals. And it's the oxidized LDL that triggers the immune response. Your body sends white blood cells called macrophages to clean up the oxidized particles. Those macrophages gorge on the oxidized LDL and become foam cells, bloated, lipid-filled immune cells that accumulate inside the arterial wall and form the core of the plaque. This is the critical point. The process is driven by oxidation and inflammation, not just by the amount of cholesterol in your blood. You can lower cholesterol levels with a statin, and statins do reduce cardiovascular events, when that is well established, but the statin does not directly address the oxidative damage or the inflammatory cascade happening inside the arterial wall. A 2017 landmark study called CANTOS, published in the New England Journal of Medicine, tested an anti-inflammatory drug, canakinumab, in patients who had already had heart attacks and were already on statins. The drug lowered inflammation without affecting cholesterol at all, and it reduced the risk of further cardiovascular events. This study was pivotal because it proved what researchers had suspected for years. Inflammation is an independent driver of cardiovascular disease, separate from cholesterol levels alone. So what is your body's signal? Translate it, and it's remarkably specific. My arterial walls are under oxidative assault. The LDL inside my walls is being oxidized. Yet the inflammation is building. I need antioxidant protection and anti-inflammatory support at the vascular level. That's the message. Not, I need lower numbers. The message is I need protection at the wall. Now let's look at what standard treatment does through this lens. Statins, the most commonly prescribed cardiovascular drug in the world, work by inhibiting the enzyme that produces cholesterol in the liver. They lower LDL. They do. And the data on statins reducing cardiovascular events in high-risk patients is real and significant. I'm not going to undermine that. But here's what statins don't do. They don't directly reduce the oxidation of LDL particles inside the arterial wall. They don't directly quench the free radicals that are damaging your endothelium. And they don't directly increase the activity of your body's own antioxidant enzymes. Enzymes like paraoxonase 1, which your HDL uses to break down oxidized lipids. The signal says, I need antioxidant protection at the arterial wall. The statin says, I'll reduce how much cholesterol your liver produces. Those are not the same thing. The statin is managing a risk factor. The signal is asking for something different, direct protection of the tissue under assault. Long-term statin use is also associated with side effects that affect a meaningful percentage of patients. Muscle pain occurs in 5 to 20% of users, according to various studies. A 2010 Lancet meta-analysis of over 90,000 patients found a 9% increased risk of new-onset diabetes. Well, these are trade-offs that many patients accept because the cardiovascular benefit outweighs the risks. And for high-risk patients, that calculus often makes sense. But it does raise the question, is there something that could complement the statin by addressing the oxidative and inflammatory process that the drug doesn't reach? There is, and you can buy it at any grocery store. Pomegranate juice, specifically. The polyphenolic compounds in pomegranate, punicalagins, ellagic acid, and anthocyanins, which make it one of the most potent antioxidant beverages ever tested. And the reason this works is not because it's some exotic superfood. It's because it delivers exactly what your arterial walls have been asking for. Your body asked for antioxidant protection against LDL oxidation. The pomegranate juice has been shown to directly reduce the oxidation of LDL particles. A study led by Michael Aviram at the Technion Israel Institute of Technology and the Rambam Medical Center, published in Clinical Nutrition in 2004, found that pomegranate juice consumption reduced LDL susceptibility to oxidation by up to 59% in patients with carotid artery stenosis. That's a direct hit on the process that drives plaque formation. Your body asked for protection at the arterial wall. That same study measured carotid intima media thickness. IMT, which is a clinical measurement of arterial wall thickening and a recognized marker of atherosclerosis progression. In the control group, patients who didn't drink pomegranate juice, IMT increased by 9% over 1 year. In the pomegranate juice group, MT decreased by up to 30% after 1 year. The arterial walls actually got thinner. The researchers also found that systolic blood pressure decreased by 12% and serum peroxygenase 1 activity, your body's own LDL protecting enzyme, increased by 83%. Your body asked for anti-inflammatory support. Pomegranate polyphenols have been shown to reduce the production of pro-inflammatory cytokines, the chemical messengers that drive the inflammatory cascade inside arterial walls. A 2022 study published in Frontiers in Pharmacology demonstrated that pomegranate peel extract reduced plaque necrosis, decreased macrophage infiltration, and lowered markers of oxidative damage in arterial lesions in an advanced atherosclerosis animal model. Now, I need to be honest with you about the full picture. A larger, more rigorous study, a randomized, double-blind trial led by Davidson and published in the American Journal of Cardiology in 2009, involving 289 participants, found that pomegranate juice did not significantly slow overall carotid EMT progression in the general study population of moderate-risk patients. However, in subgroups with the highest levels of oxidative stress, lipid peroxidation, and unfavorable triglyceride to HDL ratios, pomegranate juice did show significantly less arterial wall thickening. The benefit appeared to be strongest in the people who needed it most, those with the highest oxidative burden. This tells you something important. Pomegranate juice is not a universal magic bullet. It appears to work best in people whose arterial disease is driven primarily by oxidative stress, which, but as the research increasingly suggests, is a very large proportion of people with atherosclerosis, but not necessarily everyone. The statin manages your cholesterol number. The pomegranate juice addresses the oxidative environment inside the wall. They work at different layers, and the research suggests they may work better together than either one alone. Here's the protocol. The dose used in the landmark Aviram study was 50 milliliters per day. That's less than a quarter cup. The Davidson study used 240 milliliters, about 1 cup. A reasonable daily dose supported by the research is 4 to 8 ounces of pure pomegranate juice per day. The key word is pure. You want 100% pomegranate juice, not pomegranate-flavored cocktail, which is mostly apple juice and sugar. Check the label. The only ingredient should be pomegranate juice. Brands like Pom Wonderful are the ones most commonly used in clinical research. Timing. Morning is ideal. Drink it with or after breakfast. Some people dilute it with water if the tartness is too strong. That's fine. The polyphenols are still active either way. Timeline. The Aviram study showed measurable changes in LDL oxidation within weeks, with significant IMT changes at 3 months and continuing improvement through 1 year. This is not an overnight fix. You're supporting a slow, cumulative antioxidant process. Commit to daily consumption for at least 3 months before evaluating whether you notice any difference in how you feel. The deeper arterial changes, the ones that show up on imaging, take 6 to 12 months. Contraindications. Pay attention. Pomegranate juice can interact with certain medications. Yet if you are on blood pressure medication, pomegranate may enhance the blood pressure lowering effect, which could cause your pressure to drop too low. Monitor your readings and inform your doctor. If you are on statins, there is some evidence that pomegranate compounds may affect how certain statins are metabolized in the liver, specifically through the CYP3A4 enzyme pathway. If you're on atorvastatin or simvastatin, discuss adding pomegranate juice with your doctor or pharmacist. If you are on blood thinners like warfarin, pomegranate may have mild antiplatelet effects. Again, talk to your doctor. And if you're diabetic, be aware that pomegranate juice does contain natural sugars, roughly 31 grams per cup. Factor it into your carbohydrate management. The most common mistake: buying pomegranate-flavored drinks instead of pure juice. Eat or drinking it inconsistently. The clinical benefits in the research came from daily, sustained consumption over months. Occasional use likely won't produce measurable effects. Here's what I want you to carry away from this. Your cardiovascular system has been sending a specific signal, not lower my cholesterol number, but protect my arterial walls from oxidative damage. For decades, the standard approach has been to manage the number, and that matters. It reduces risk. But the signal underneath, the oxidation, the inflammation, the damage at the wall, that signal has largely gone unanswered for most patients. A glass of pomegranate juice costs about $1. It delivers some of the most potent antioxidant protection ever measured in a beverage. It has been shown in published, peer-reviewed research to reduce LDL oxidation, increase the body's own antioxidant enzyme activity, lower blood pressure, and, in certain populations, measurably reduce arterial wall thickening. It is not a replacement for medical treatment. It is a complement to it, and it addresses a layer of cardiovascular protection that your medication was never designed to reach. One more time, because your heart is literally at stake, and I don't take that lightly. Do not stop your statin. Do not stop your blood pressure medication. Do not change any prescription without your cardiologist's guidance. What I'm suggesting is that you add a glass of pomegranate juice to your morning and bring the research to your next appointment. Ask your doctor, could this complement what I'm already doing? That's the conversation worth having. Your body has been trying to tell you something for years. But the pills turn down the volume. The juice may help answer the call, and it turns out your body knew what it needed all along. You just have to listen long enough to hear it. If someone you care about is dealing with cardiovascular concerns and has never heard about the pomegranate research, send them this video. Not because I need the views, because they deserve the information. Take care of yourself, and take care of that heart. It's been taking care of you.